welcome to our okay. Welcome to our today's international webinar. After a long time, due to COVID situation, we are not arrange face-to-face seminar. That's why we are arranging Zoom meeting, Zoom webinar. After a long time, we attend here today. Today, there is a seminar in international webinar, management of psoriasis in COVID-19 pandemic. And today, first of all, I just inform everyone that today, the death rate, we are passing a big travel time. Today, there is a 258 death rate and new cases is 14,925. So it's a horrible information for all of us. So I think everyone should obey our concern that we should maintain our procedure. Okay. Now, today we are starting our international webinar. First of all, I like to invite our chairperson and president Psoriasis Awareness Club, Professor Samuel Haq, to say something welcome address. Okay. And our today's panel of expert is Professor MD Kamrul Hassan Jagirdar, Chairman, Department of Dermatology and Venereology, Bangabandhu Sheikh Mujib Medical University, Dhaka. And another our panel of expert is Professor Mohammad Abul Qasim Chaudhary. He is also head of the Department of Chittagong Medical College Hospital. And another our panel of expert is Dr. Rebecca Sultana. She is also head of the Department of Kurmitula General Hospital, Dhaka, Bangladesh. Now I like to invite our chairperson, Professor Mohammad Samuel Haq, to say something in as address. Welcome address. Okay, Professor Samuel Haq.
Thank you, Dr. Abu Hana. It is my great pleasure to welcome you all to this international webinar organized by Psoriasis Awareness Club, Bangladesh. You know, the Psoriasis Awareness Club is a non-profitable organization with a common platform of dermatologists, patients, and social worker and the social activists. They are working for the welfare of psoriasis disease patient. Now we know that we are facing a unique challenge of COVID-19. We understand that this new situation made us in confusion regarding the impact of COVID-19 to psoriasis patient. Every day there are a lot of changes coming. Before we heard that COVID has no impact on psoriasis. Now we are hearing COVID has impact on psoriasis patient. And a lot of changes are coming in the management and a lot of changes are coming in the guideline. So today we'll hear from our speaker. He is a renowned dermatologist, Professor Luis Pong. He's from Barcelona, Spain. And he's a renowned professor as well as he is a researcher also. And he did a lot of works on this COVID-19. So we choose him and he happily agreed to give his lecture to us. And it is an exchange program. And we will learn from him. We can exchange our views and it is just an interactive program also. So let us welcome you all, Professor Luis Pong, to our webinar. And with us, we have also welcoming our dignified panelist, Professor Kamrul Hassan Jagirdar, who is the chairman of the Bangabandhu Sheikh Mujib University in the Department of Dermatology and Venereology. We have also panelist Professor Abul Qasim Chaudhary, who is the professor and head of the department in Chattogram Medical College, and Dr. Rebecca Sultana, who is a head of the department in Kurmitala General Hospital. All these hospitals are COVID dedicated hospital. And these panelists have large and have many experience on this COVID-19. So we'll hear from their view and we'll have a good time now. Let us start our program. We are welcoming Professor Louis Fang to give his valuable speech. Professor Louis Fang.
Thank you very much for your nice and kind invitation to participate in this international webinar. Professor Mohamed Samiul Hook and all the members of this panel of experts and our moderator. So I'm the director of the Department of Dermatology of the Hospital de la Santa Creu in São Paulo. My family name is pronounced Puig. This means peak or hill or mountain in Catalan, which is my mother language. And I'm also a member of the International Psoriasis Council Board. And it's my pleasure to participate in this conference. These are my conflicts of interest, and I would like to ask you to please mute your microphones in order to prevent this kind of distractions or
Anis,
sounds. Thank you very much.
Everyone requested to mute himself or herself for smooth.
Sir.
Now I'm not muted now. Thank you very much.
Yes.
So I would like to start with this is a historic image of the appearance of our hospital on February, March of last year. You can see that many of our halls were converted into wards. Even some of the operation rooms were converted into intensive care units, and we had up to more than 300 patients at our hospital, which is a 450 bed hospital. Of course, the ICU doubled its capacity. Everybody went to care for those patients. And this led to some, even dermatologists, and even nowadays we're doing some on-call activities with COVID patients. But since most of us were attending those patients, one of the consequences, the good consequences that happened, was that in the Spanish dermatologists were able to gather their cases and to publish a review of the different cutaneous manifestations of COVID-19 with more than 375 patients from Spain. This is something that you of course already know, but this was a byproduct of this great disruption of our system that took place. And many things have changed also as regards the way in which we care for our patients nowadays. We are using much more teledermatology and phone calls or teledermatology appointments, especially for second visits in our patients. Our prescriptions and refills of biologics decreased a lot, and there were some changes. But most of these changes had to do with the epidemic itself. So now we are on the fifth wave of this epidemic. So this is what you can see on the screen. The first wave mostly affected elderly people, and the population was not exposed or did not have any antibodies, were not vaccinated, and the mortality was very high. And there was a second epidemic after the summer. And the variant that appeared here was eventually the one that appeared in UK, the Alpha. And then we have a third wave, a fourth wave, and now we have had a very strong fifth wave. But you can see a difference here. This is the prevalence of the disease in our country. That's Catalonia, 7 million inhabitants. But you can see here that most of the patients nowadays are young people, less than 30 in most cases, or 30 to 50. So correspondingly, the severity is not so high, so severe, and the mortality is also lower. You can see here the trends in daily positive cases across the time. You can see on the right bottom the way in which the intensive care unit occupation has increased. Also, the occupation of our wards. Now we have already 2 wards with COVID patients, quite below the situation 1 year ago, but the mortality is relatively low. So we have plenty of patients in our intensive care unit. We have like 50 patients on hospital wards and like 30, 35 in this hospital. But you can see that the mortality is much lower. And this has mostly to do with vaccination, which currently accounts for more than 50% of our population. And in persons older than 60 is, I would say, 90 to 100% of the population. So it's mostly young people, those who are not fully vaccinated. So the population of Spain is like 47 million. You can see here 25 million persons have been vaccinated. This is a graph from the internet. I took it today. It can compare the situation in Spain, France, Italy with those in some other countries. You can see here Turkey, Saudi Arabia, India, and Bangladesh. So where the proportion of the population who has been fully vaccinated is lower. And this might account for some differences. You will know that the COVID, the SARS-CoV-2, the virus that causes COVID, originated in bats, and it's able to produce a very strong adaptive and non-specific immune activation, especially on the setting of lymphocyte depression. And this gives rise to the cytokine storm that characterizes the bad course. Another thing that is quite peculiar of this virus is that it prevents the normal interferon-mediated basis of the early innate immune response against viruses. So COVID, the SARS-CoV-2, the coronavirus, are let's say adapted to live in bats, so which mount a very strong interferon response. So they have natural mechanisms of selected mechanisms to prevent this kind of interferon response. And this is the reason why in some patients where the interferon response is suboptimal, the disease can be much more severe. And this is all well known by you. And we also know that there are several genetic factors that increase the risk for disease and also for severe disease. Some of them come from the Neanderthals, and some of them are protective, and some of them are harmful. And most of this data come from studies in the Indian subcontinent, also in Pakistan and Bangladesh, I understand. So it is very interesting to see the way in which history and evolution has modified our response to coronaviruses. It is very important to remember that whenever we got an infection with coronaviruses, they can be those of the common cold, or also those of SARS, MERS, and also the COVID-19. There's a very initial innate type 1 interferon-mediated immune response. And then there's an adaptive immune response in which specific helper and cytotoxic cells are created and directed against the viruses. And also specific B cells and plasma cells that produce IgM, IgG, and IgA, ideally neutralizing antibodies, are able to bind to the virus and neutralize it, even ideally on the nasopharyngeal areas. In order to achieve this, we should be using intranasal vaccines, because most of the immunity elicited by subcutaneous or intramuscular vaccines gives rise to IgG and a bit of IgM. And this is interesting to take into account that this response is boosted in patients who have, or in individuals who have already suffered COVID disease. From the beginning, it was there was a strong interest to see if there's any kind of association between the severity of the infection of COVID-19 and other predisposing conditions. And in all studies, we have seen that age, especially above 60, weight, and especially body mass index above 30, male sex, and also non-white ethnicity are risk factors for severe disease. It is interesting to see that only in this study, some diseases such as skin conditions and even psoriasis has been associated to an increased risk of infection. But interestingly enough, that these infections are not more severe than those that occur in other people, in other populations. And this is for instance, as we see, the risk of requiring mechanical ventilation, again, is higher in elderly males, especially also obese ones, and patients with a disadvantage from a socioeconomic perspective or non-white ethnicity. But in this meta-analysis, some conditions, as a matter of fact, decrease the risk of this of requiring mechanical ventilation, that is, of severe COVID disease. Completely opposite to what happens with diabetes, hypertension, COPD, or coronary artery disease that we all know that increase the risk of severe disease. And it has been said that some of the mediators or the inflammatory pathways that are activated in psoriasis are also activated in the successful response against SARS-CoV-2. There's been a great interest on knowing which is the prevalence and the clinical outcomes of COVID-19 in patients with autoimmune diseases, which are immunosuppressed either by the disease itself or by their treatment. And this is a very interesting meta-analysis that showed that glucocorticosteroids increase the risk of COVID-19 and its severe outcomes, even though you all know that the dexamethasone is used with some success in patients with very severe disease with a cytokine storm. And on the other hand, that monotherapy with DMARDs, and especially anti-tumor necrosis factor therapy, and this is highly relevant as regards psoriasis, reduces the risk of severe COVID-19. Partly, perhaps, because TNF-alpha is a very important mediator of this cytokine storm, of this inflammation, which is the main cause for the adult respiratory distress syndrome that characterizes a bad prognosis of COVID. There was an initial concern that patients with psoriasis treated with the currently available biologicals might have an increased risk, partly because of the analysis of some results from upper respiratory way infections in patients treated with secukinumab and other drugs, but metapavitals did not show any increased risk. So the conclusion was first summarized in this paper that I wrote with my Portuguese colleague and friend, Tiago Torres, that provided some indications regarding the way in which we should deal with our patients under treatment with biologicals. And there was the initial studies came from Verona, which was the first European country struck hard by the pandemic, and they showed in their meta-analysis a cumulative demographic study from several hospitals that there was no early signal of an increased hospitalization or death from COVID-19 in patients with psoriasis, despite the fact that psoriasis patients are often burdened by associated comorbid disease, which increases the risk for bad prognosis with COVID. For instance, obesity or hypertension, diabetes, obesity, etc. So this is one factor that must be taken into account. Despite this increased risk associated with comorbidities, our patients had a decreased risk of getting into hospital, even getting infected or having a bad prognosis. And there are several causes for that. One might be the treatment, and the other one might be that these patients were more successful at isolating themselves. We'll discuss that. This was the first study that took into account a denominator, a known population, because it was a registry study. And we saw that even though there was a trend or an increased risk for infection or for admission to intensive care units or even for death, in none of these cases were these trends or this evidence significant. So there was no significant increase of infection, of increased worsened prognosis, and of death because of COVID in patients with psoriasis from a registry. And several other registries were implemented. One of them in which we participated is the PSOProtect, which was driven by several countries, but it's a really international registry. And the results from this registry, from this study, have been published recently. Out of this population of more than 1,500 patients, 20% of them were hospitalized. All of them had PCR or highly high suspicion of COVID disease. Only 20% were hospitalized. Only 2% of them died, and in 93% there was a full recovery. And when we analyze which were the factors that contributed to hospitalization, of course, being male, being elderly, increasing age, and non-white ethnicity were associated with an increased risk of hospitalization. Getting non-biologic systemic treatments such as methotrexate, cyclosporine, and the like were associated with an increased risk for hospitalization too. And then there were some interesting factors. Of course, having COPD or asthma was associated with a worsened prognosis that required hospitalization, and being Spanish. Perhaps in Spain, we were more scared, or our system is more likely to get those patients with an infection into hospital. So as our hospitals were overburdened in the first wave of the epidemic. But this is the most important. Biologics seem to be protective. And this has also been shown in Israel, where tumor necrosis factors have been shown to be protective as regards hospitalization, not death, but protect against hospitalization because of COVID-19, as compared to methotrexate or ustekinumab in this study. So they are protective against high risk, bad prognosis of COVID infection. And the same in another population-based, in this population-based study, you can see that using methotrexate was associated with increased risk, but not biologics. That's quite interesting. As a matter of fact, as we'll discuss later on. A very recently published study from France has shown that in this case, there was no increased risk of hospital mortality for patients with psoriasis associated with treatment, not biologics, not systemics. So these results support the maintenance of systemic treatment for psoriasis during the epidemic. It was shown that the probability to get into hospital was a bit higher in those patients who received treatment, regardless of the treatment. And this was partly probably because of the associated comorbidities of those patients. But the mortality was not affected by treatment. This is a bit contrary to some other populations and some other studies. So our conclusions were that the patients might be protected. Perhaps they are protected because of increased isolation. The treatment should be maintained, but perhaps the administration should be lengthened in some patients. Of course, a patient with active COVID should not start or should discontinue treatment, but in patients with obesity, cardiovascular disease, chronic lung disease, hypertension, diabetes, and elderly patients should increase their isolation and perhaps interrupt the treatment, especially if they're receiving treatment with methotrexate or cyclosporine. And this is interesting because in this study, it has been shown that patients receiving biologicals tend to be more likely to be isolated to prevent exposure than patients who were not under treatment with biological agents. So perhaps this concern has had a good effect on our patient population. And there's a hand raised. We are able to chat or to discuss. So I will stop here and I will start asking. So is COVID vaccine safe to take if someone have psoriasis? Yes, it is, and we will discuss that. There's no reason why a vaccine cannot be taken. There are some cases of worsening of psoriasis because following administration of vaccine, but this is since the vaccines induce an immune activation with increased levels of interferon and the like, and some people have a fever and feel a bit of malaise. Secondly to this activation, in some cases, some bouts of psoriasis have been described, but this is the same with vasculitis and some other issues, but this is very rare and should not discourage any patient from getting their vaccination. There's a question from Dr. Hossein. What can be treatment for psoriasis in a country like Bangladesh? Is it curable? Well, I think this is not the time to discuss that, but I'm quite sure that the members of this community will be happy to answer Dr. Hossein. And in our country, admitted COVID patients are treated with injectable corticosteroids, which might have severe impact. Well, the impact of corticosteroids on psoriasis is not so strong. At least this is what recent studies from Germany and United States show. So we know that changing the doses of corticosteroids can worsen the disease of psoriasis when the doses decrease, or after some time there might be a flare, but this is not so commonplace. So I would say if you need to give dexamethasone to one patient at the intensive care unit or at the hospital ward because of COVID, you should not be worried about what happens to the psoriasis. You will be able to care for it later on. So if you have to do dexamethasone, you should. But if the patient is on prednisone or any dose of prednisone, like higher than 10, 15 milligrams for any disease, it has been shown, and we will discuss that they increase the risk of severe COVID, and you should decrease that dose or stop the treatment. With some exceptions. If you have a patient on lupus and you are treating this patient and you stop treatment, perhaps the activity of the disease will induce higher immunosuppression than treating the lupus with a small dose of corticosteroids. Then about methotrexate or cyclosporine, if there's COVID infection and the disease is especially if severe, methotrexate or cyclosporine should be stopped. But of course, in many cases, when you have the patient comes ill, you will stop the treatment. So there's no reason why you can prevent that. Now, if the patient is at high risk, so imagine that we have a patient who is obese, has a COPD, is diabetic. This patient, if in contact before the COVID manifests itself, I would strongly advise to stop or methotrexate or cyclosporine, not biologics. And then another question, if the patient observe, well, diet and psoriasis, I think this falls a bit beyond the gamut of this the topic of this talk. Flares of psoriasis, no, we have had flares of psoriasis because the patient has stopped the treatment, not because of the treatment with the COVID treatment. So on the other hand, there are not so many treatments for COVID apart from dexamethasone and perhaps tocilizumab, and of course all the supporting anti-thrombotic agents, heparin, oxygen, and the like. What about vaccination? We will discuss that. So methotrexate has shown also anti-TNF-alpha agents and methotrexate have been shown to decrease a bit the production of protecting antibodies, but it is not clear if this decrease is significant. So perhaps clinically it's not relevant, and the cellular immune response does not seem to be impaired by methotrexate. We will discuss that. Okay, so let's continue. Well, we had this one example of what happens vaccination. Yes, during the COVID period, in many countries, we saw some patients who stopped treatment on their own, or perhaps by the advice of some friends, even their general practitioners. Even some dermatologists were scared because there was a lot of unknowns at that time. So many patients stopped the treatment. And this is an example from a hospital in Barcelona and from several hospitals, not just in Barcelona, where there was a drop in the initiation and also in the continuation in the refilling of prescriptions for biologicals in patients with psoriasis. The consequence of this was that some patients came with a very severe flare of disease with or without COVID. the patients flared because they stopped the treatment. And this is what happened in these patients who had been under treatment with an anti-TNF alpha agent, I think. And of course, we must remember the half-lives and also the ability of some drugs to maintain their efficacy even in the absence of drug levels. So in that respect, in the COVID pandemic, I would prefer using drugs such as risankizumab or guselkumab, or perhaps in the future, bimekizumab, which have been shown to persist in their effect beyond their pharmacokinetic, their 4 times their half-lives. That's interesting. So based on that, also there have been some case reports of patients who were received guselkumab, continued receiving guselkumab, ixekizumab, some other biologics during their disease, and there was even some kind of improvement. Of course, no clear-cut causality can be inferred from these case studies, but in no patient was the disease confirmed to worsen, COVID, to worsen because of the treatment with any biologic. On the opposite, it was perhaps methotrexate cyclosporine which might have led to some worsening of the disease. So there are some, of course, some immunologic explanations for this. Generally speaking, the antiviral mechanisms of immunity, both innate and adaptive immunity, are not modified or interfered with by any of the biologicals available, perhaps with the exception of ustekinumab because it blocks IL-12. Whereas on the other hand, prednisone, corticosteroids, and of course, JAK inhibitors might impair this. On the other hand, during the phase of cytokine storm, some of the biologicals, such as those that block IL-17 or TNF-alpha, might have been useful in terms of preventing the evolution of this, or the bad prognosis of the cytokine storm. There are some studies that, and even clinical trials that have been done, but the results are not clear for the time being. There was a very, I would say this is a very good position statement about the way in which the different treatments can modify the risk of COVID. And the conclusion was that as regards the biologics, there was a minimal to negligible risk as regards the overall infection with COVID, with of course SARS-CoV-2. So we would not stop these treatments. And even for the other immunosuppressants, the risk of worsening outcomes is low. So patients might continue on treatments unless they become infected. Asymptomatic patients who test positive for COVID-19, if they do not develop disease, might also continue therapy, especially if they are on biologics. But of course, there's a need of follow-up. And for the patients with symptomatic infection, treatments should be assessed on an individual basis, and I would prefer to stop cyclosporine or methotrexate. As regards biologics, there's no, the stopping of them or not doesn't make a big difference because of their half-lives. That's not the case with cyclosporine, prednisone, or methotrexate. And here is the situation of this patient after he started ixekizumab in this case. Okay. So what about JAK? So JAK is very important in mediating the interferon alpha and gamma signaling. So inhibiting this with JAK stats might be detrimental. I would recommend to stop these treatments. The same with prednisone, especially at doses higher than 10 milligrams per day. And as regards cyclosporine and methotrexate, they might inhibit to establish the immune memory. So they might be more important in terms of preventing the development of protection following vaccination than in terms of modifying the response or the evolution of COVID. So I would say it might be better to stop these treatments, but of course, each decision must be individualized. So the ideal treatment for those patients with psoriasis that are not infected, while they're not even in a high pandemic area, should be keeping on biologicals, preferably those with long half-lives, or I would say long administration times, those with a flexible dosing. I would prefer also biologics because no monitoring is required, so we can prevent hospital attendance, blood tests, and we can provide telephonic follow-up. And it is important to maintain the response. And on the other hand, I would prefer not to be using cyclosporine or methotrexate on those patients. There's no evidence whatsoever that the patients receiving systemic treatments, including biologics, have had an increased risk of hospitalization, death, or even infection. This comes from a meta-analysis. And now I'm going to discuss a little bit the vaccination issues. Nowadays, we have two main types of vaccines. One of them are RNA-based vaccines. The other one are vaccines made with adenoviruses, in most cases, which might be non-replicating, but are the carriers of the viral DNA of coronavirus. So these are the two mechanisms and by which these vaccines work. In the case of adenoviruses, they can be from chimpanzee or adenovirus type 6. There are several options in that respect. This is AstraZeneca, and also the Russian, some of the Russian vaccines, the Sputnik, and the way in which these vaccines work is that they insert the DNA or the RNA in the case of coronavirus into the dendritic cells, and they start to produce the proteins, the spike protein and some other proteins, and there a B cell response, which is helped by T cells, and eventually this adaptive immune response gives rise to protective neutralizing antibodies, and also to an immune-based based on natural killer effector cells, T regulatory cells, and memory T cells, especially in the lungs and the upper airways, which prevent the infection. In the case of RNA vaccines, the RNA itself is transcribed within not just the dendritic cells, also the muscle cells, and the result is the production of a lot of S protein, which is of course an extraneous, foreign protein, and this leads to the activation of the immune system, the production of type 1 interferons, cytokines, chemokines, and also of course antibodies directed against the S protein, which will be neutralizing for the coronaviruses. Okay, so now we know that following the vaccination, especially following 2 doses, or in the case of the adenovirus 26 vaccination, following 1 dose, there's an increase in the titer of antibodies that, generally speaking, tends to increase even more following 2 doses. In some patients, this increase is extremely high, and these are patients who have had prior exposure to coronavirus. So if patients who have had coronavirus, perhaps just 1 shot would be enough. On the other hand, you can see that in patients, this is a further demonstration of this. You can see in seronegative patients, you get, especially in younger patients, you get an increase in the response. Whereas in seropositive patients, regardless of the age, there is a very strong antibody and also cellular response following just 1 administration of this RNA vaccine. That's I think that was the Moderna vaccine. No, sorry, it was British Medical. That was the Pfizer. And this is another example of this, the way in which with time, the antibody responses in terms of IgA or IgM increase in patients who are naive, whereas in patients who are exposed, this increase is already present from the beginning, and the response is not so enhanced, even though it is already very high, because these patients have had natural immunity. Okay. And this is another situation which can happen. In some countries, only the AstraZeneca vaccine was given to patients. Then there was the problem with thromboembolic events, and some of these patients did not receive a second dose, or perhaps the second dose that they received was the mRNA from Pfizer, for instance. And this study shows that in the protection after just one dose is relatively low, but it can be boosted strongly by not just the same vaccine, the AstraZeneca vaccine, but also by the administration of the mRNA vaccine from Pfizer and BioNTech. Okay. So the second dose in patients who have received just one dose of the chimpanzee adenovirus vaccine from AstraZeneca, you can get a high boosting of these antibody titers with a second dose of not AstraZeneca, but perhaps Pfizer vaccine. This is interesting. It might be interesting for your country because, you know, when there are changes in the variants, their RNA can be modified. So it's much easier to modify the RNA in an mRNA-based vaccine so that the different spike proteins can be recognized better. And it is interesting to see that the neutralizing titers of antibodies against new variants of the coronaviruses decrease over time. So this is these are the titers as regards virus neutralization of the original Wuhan variant. You can see this is the first variant that was shown to have a decrease, that was shown to change. That was the Alpha variant in UK. And nowadays we have data from other variants, and the Delta variant has several reasons why the protection afforded by vaccines can be a bit lower, and also the infectivity and the contagiousness of the Delta variant is much higher. So it is important to keep track on these variants of concern. For instance, in Spain nowadays, most of the new infections are due to the Delta variant. Most of our cases nowadays in this fifth wave are Delta, but we have also seen some cases from the Lambda variant, which has come from South America. And you can see here that for some vaccines, these are different vaccines, and you can see here that there's a decrease in the efficacy in terms of effectiveness as regards neutralization. The differences vary across vaccines. With the Pfizer vaccine, it seems to be a bit lower, the variation. The AstraZeneca vaccine seems to be a little less protecting, especially after just one dose. But with the second dose, you can see that the titers, the levels of protection become very high. So you can see here with the Pfizer vaccine up to 90% of protection, even though 1 in 10 can still have the disease, but less severe disease. With AstraZeneca, 2 doses, you get 70% protection, which is high enough to be protective. So what is the effect of the different treatments of psoriasis as regards the efficacy of vaccinations? So we have some data that suggests that cyclosporin, as well as methotrexate at high doses, might decrease the humoral response against some of the currently available vaccines that we have been using. So this is from historic or from bibliographic references. Now we have already some data regarding COVID vaccines, as I've just shown you. And it is also very interesting to see that there was some evidence that infliximab might decrease the response in terms of neutralizing antibodies against some of the prior vaccines. And this has also been shown with COVID. On the other hand, in no case has ever been shown that ustekinumab, so blockers of IL-23 or IL-17, have any kind of effect on the production of antibodies or in the protection afforded by T cells against any virus. So these were the conclusions based on this. So for some authors, that anti-TNF alpha agents seem to be safe. Corticosteroids, JAK inhibitors, and perhaps methotrexate should be stopped 1 week or prior, 2 weeks after the vaccination to not hamper, to prevent hampering the antibody production. But now we know, especially this came from an initial study in patients with inflammatory bowel disease, that in some of these patients, the titer of antibodies was a bit lower. So this might or might not be clinically relevant, but you can imagine that if the titer is lower because of anti-TNF alpha agents, and it's also lower because of the new variant, it's a Delta variant, this might eventually be significant, okay? And this is a very recently published paper from the St. John's Hospital that shows in patients. As a matter of fact, there were patients with psoriasis on methotrexate, IL-17, anti-TNF alpha, anti-IL-23, and controls. And these patients received one vaccine of one Pfizer vaccine, and then received the next one. But this data, this study corresponds just to the first vaccine. And the conclusions of this was that the titers, the neutralizing titers against the wild type coronavirus was significantly lower in patients receiving methotrexate than in controls, but was preserved in those receiving targeted biologicals. So there was a change in that respect. Methotrexate decreased the immunity. And then on the other hand, you can see here, sorry, this is that the cellular immune response were induced in all groups, you can see here, but they were not attenuated in patients receiving either biologicals or methotrexate. So a bit of a decrease on the serologic response antibodies in methotrexate. You can see it here, here, and you can see that there's no change in terms of the other drugs, the other biologicals, and no evidence of any significant difference as regards the T cell responses, both in terms of T1 and T17 cells. Okay, and these are some additional data regarding what happens with the alpha variant. So this is wild type, the Wuhan variant. You can see with the alpha, and the same can be seen, of course, we can expect to be seen with the delta. You can see here a bit of a decrease in the terms of the neutralization titers, but still this seemed not to be clinically relevant. And again, in another study that shows that 15% of patients with different types of immune-mediated inflammatory diseases, psoriasis, lupus erythematosus, and Crohn's disease, have also a decrease in the efficacy of vaccination, regardless of the treatment in these cases, especially in those patients, of course, with no prior infection. Finally, another evidence that methotrexate hampers the immunogenicity to the Pfizer vaccine in patients not just with psoriasis, but with other immune-mediated inflammatory diseases. I'm all trying to get rid of this. And finally, 2 comments regarding the potential adverse effects. Of course, apart from the specific adverse events of vaccines, you know, the Moderna arm, the fever, the malaise, the lymph node disease, the allergy in some patients, there's some consequences of the immune activation. It's an adjuvant, as a matter of fact. And as a consequence, you can see occasionally vasculitis. In some patients, you can see flares of psoriasis, as you can see with any infection, and in some cases, even following the Chinese vaccine, a flare of pustular psoriasis has also been reported. So generally speaking, this is the practical information with which I would like to close this talk. One is that the methotrexate and cyclosporine should be stopped because there's a risk in decreasing, perhaps clinically in a clinically relevant fashion, the immunity afforded by the vaccine. JAK inhibitors should not be used unless in the context of the treatment of patients with severe COVID disease at the ICU. And then TNF-alpha blockers might decrease the production of antibodies, and there's no clear evidence, but perhaps this treatment should be stopped 1 or 2 weeks prior to the vaccine, and should not be stopped until 3-4 weeks after the vaccination. And as regards IL-17 and IL-23 inhibitors, there's no evidence whatsoever that we should modify the course of treatment in our patients because of a vaccination. And then there are some unsolved issues, such as the time interval between doses, the vaccination of patients who have had COVID-19, which might mount an increased response. Perhaps you can delay this vaccination. What happens in the setting of infection, intercurrent infection with COVID with the SARS-CoV-2 between doses, and this might increase the risk of appearance of resistant variants. When we revaccinate with RNA, and probably because of the decrease in the content in the titers of antibodies, we might be needing to revaccinate our patients, our population, every 6 months or every year, and perhaps we should adapt the RNA content of the vaccines to the changes in the spike proteins that eventually occur following selection of different variants. And then there's in those countries which are using adenovirus vaccines, everybody is using them, but we must remember that one dose is less protective. It might be better for young individuals because of the risk of their lower risk in terms of severity of the disease, but on the other hand, with some vaccines, the increased risk for some embolic events, thromboembolic events. And in terms of the second dose, it has been shown that at least with AstraZeneca, it can be the same vaccine or another vaccine. And there are experiments ongoing in terms of the possibility of changing the vector in order to increase the immunity of the vaccines. And this closes my talk, and I would be more than happy to listen to your questions.
Thank you, our learned speaker, Professor Luis. Thanks, special thanks for your elaborate and nice presentation. There are, though you have says everything in your lectures, but there are some questions in our chat box which you have already given some answers already.
Yes.
So besides this, there are some questions that if someone taking MTX or cyclosporin or apremilast, can we take COVID vaccination? If
I would recommend to switch, if possible, to another drug, especially for the sake of vaccination, to maximize the probability of getting the patient protected. Then after the immune response has mounted, and it can take perhaps 3 weeks, 1 month, you could restart the treatment.
Yeah, okay. Is there another question? Do the comorbidities associated with psoriasis worsen outcome of COVID-19?
Well, the comorbidities do not necessarily worsen, but it might impairment of the specific organs can appear after COVID. So for instance, in a patient with cardiovascular disease, if COVID causes myocarditis, of course, it will be the prognosis will be worse. That's an example. Or COPD, of course, the pneumonia because of COVID is much worse if the patient has asthma or COPD or diabetes.
Yes, yes. There is another question here. If some patients develops COVID-19, should they stop their systemic therapy until recovery?
So the general agreement is yes, they should not start, or they should better stop their therapy. But this applies mostly to systemic agents, because if the patient is on, let's say, ustekinumab or infliximab, okay, you stop. This means that you don't get the injection after the patient has fully recovered, or at least is COVID negative. We won't discuss the long COVID, but you cannot take the biologic away from the body. But at any rate, it has never been shown that the biologic is counterproductive, is harmful. So that's okay. Now, if a patient develops COVID, I would stop methotrexate, I would stop cyclosporin, no doubt about it. I wouldn't care so much about the citrotine or well, phototherapy. The patient is unlikely to be able to get phototherapy sessions during the COVID because the patient must be isolated.
Yeah, okay, thank you. There is another question. How many times we'll wait to restart MTX, cyclosporin or apremilast after recovery from COVID?
As I told you, I would not stop them, but if you stop them, I would say once the patient is PCR negative, and it might take longer to be PCR negative, because PCR does not indicate, the positive PCR does not indicate that the virus, of course, the RNA corresponds to viral charge able to replicate. But generally speaking, if you do a PCR, then when it's negative, you can restart. On the other hand, if the patient has had mild COVID, but the patient is asymptomatic, generally speaking, I would say that 10 days after 10 days of isolation, when the patient has no symptoms, you can start quite confidently.
Yeah, thank you. Is there another questions? If someone taking MTX or cyclosporine, if he wants to take vaccination, is there necessary to stop MTX or cyclosporine or apremilast for taking vaccination?
Apremilast, there's no evidence that apremilast has such a big impact, even though it might have. If my advice to my patients who need to be vaccinated, and as a matter of fact, we have provided vaccination to all our patients under treatment for psoriasis, would be, again, to stop methotrexate 1 week before and to restart 2-3 weeks after. The same with cyclosporine. The half-life of cyclosporine and its biological effect is relatively short, as you all know, because of the flares it can produce. So if you stop cyclosporine 1 week before and you wait perhaps 3 weeks until you start, that might be okay.
Thank you. I think everyone, those who are listening these things, everyone is clear about these things, because in our Bangladesh, so many patients in our practice, someone asks, say, doctor, I just continue or taking vaccination or not? We need to stop MTX. How long? Yeah, that's why
If
I
you're
think everyone is.
yes, if you have a patient on biosimilar adalimumab, for instance, and for the sake of a vaccination, I would recommend, especially if the patient is elderly and I want to get the most of the vaccination, to stop. So to try to get the vaccination at the time when the next dose of adalimumab will be given, then delay this dose until perhaps 2-3 weeks later. So all in all, the patient would lose 1 or 2 doses of adalimumab.
Yeah. Okay. Thank you. Another question is here. Have you any experience of flare-up psoriasis during COVID treatment?
No, I have had no experience of any patient whose psoriasis flared, but in most patients, the status, if the patient has severe COVID, really nobody cares so much about psoriasis because the patient is at the intensive care unit and the like. But generally speaking, in order to the immune activation or the cytokine storm might worsen psoriasis. And you can see that, but this has not been no reason to, let's say, to interfere with the treatment of COVID or to ask for a dermatological consultation. No.
Okay, thank you. Thank you. Hopefully you are with us now. I'm going to panel of expert experience. First of all, I wants to go Dr. Rebecca Sultana. Now she is working in head of the department of Kurmitullah General Hospital, which is the COVID dedicated hospital in Bangladesh. Dr. Rebecca Sultana, do you hear me?
Unmute.
Yeah, please unmute Rebecca Sultana.
Unmute it.
Yes. Assalamu alaikum.
You are working in Kurmitullah Hospital. I am just question, just what is the prevalence or what is the number of psoriasis patients coming to your hospital during COVID situation in your hospital admitted, and how will you treat this psoriasis patient in COVID situation in Kurmitullah General Hospital?
Thank you, Dr. Ravindra Chaudhary. Thanks. I give my heartfelt thanks to Psoriasis Awareness Club to give me the opportunity to speak something in this platform in front of my mentors, my teachers. And as I am working in Kurmitullah General Hospital from the beginning of COVID, you know, it is a COVID dedicated hospital from the starting of COVID treatment. And I am with the patient from the beginning. And fortunately, I can give you some impression about my hospital, but some experience I gather. I think that the patient suffering from psoriasis, very small number of patients comes in this hospital with COVID positive or suspected case. 2 patients came here, And in such patients, I usually try to give the treatment by dividing them into three parts. That is, only psoriasis without COVID. In these patients, we give just mild cases or topical applications. If moderate to severe case and the patient is without any systemic drug, I like to start systemic drug without immunomodulating drugs. In this COVID era, I like to avoid immunomodulating drugs, but in this my experience, that epinelast, I start in some cases epinelast and works nicely. And in severe case, if the patient is with immunomodulating drugs, I like to stop, but assessing the risk benefit, sometimes I give the divide the dose in half. And in case of pustular psoriasis, we got one or two cases. Pustular psoriasis with COVID positive. Here the patients previously was treated with acetatin, and acetatin was continuing, and after COVID, the recovery from COVID, patient have no such side effects. And in case of COVID patients with pregnancy, in this case, I always try to give topical applications, and if no improvement, then we go for cyclosporine, deciding this benefit ratio.
Yeah, we all know that during COVID treatment, our patients got systemic steroid.
Yes.
Dr. Professor Lewis also said that systemic steroid taken in the COVID situation. Have you any experience to get psoriasis flare or pustular psoriasis? We all know that systemic steroid, if we give systemic steroid in psoriasis, it might turns to pustular psoriasis. Have you any experience, or you have got any psoriasis patient after taking systemic steroid during COVID treatment in your hospital?
Thank you. We are fortunate enough that steroid was given, but accordingly we decided to withdraw the steroid slowly, and if possible, short course for short duration. And in these patients, after recovery from COVID, we decide to start systemic therapy like epinelast or in some case methotrexate, but no flare up in my hospital still.
Okay, Professor Lewis, can you add, say something, please add about pustular psoriasis after
Yes.
recovery from COVID? Yeah.
Again,
how can we treat this pustular psoriasis?
well, the standard treatment for pustular psoriasis flares could be cyclosporine without having to use biologics. In our practice nowadays, biologics perhaps would be first line, either IL-17 antagonist or IL-23. But if no biologics are available, I would use cyclosporine. And of course, the patient, I understand, is already cured from COVID. If not, acetylene can be used. But I would say that the real generalized pustular psoriasis flares are very rare, almost unheard of, following changes in the doses of corticosteroids. You can see small flares of psoriasis with some pustules, which usually respond to just pushing the treatment a little bit more. But generalized pustular psoriasis, because of corticosteroids, is not so frequent as usually taught in medical schools in our practice, and this has been just recently been confirmed. And in general, it's not a necessity. As a matter of fact, in many cases of pustular psoriasis, we are using corticosteroids. So I don't know if that's your experience, but when you have a patient with pustular psoriasis, when no biologicals were available, when no cyclosporine was available, and even in many countries, still a pulse of dexamethasone can be used, or high dose, relatively high dose prednisolone can be used for those patients. So I should not be so concerned about the flare of pustular psoriasis. And if it occurs, we have many alternative medications, and I would go for anti-TNF alpha agents or other biologics.
Okay. If you use systemic steroid for pustular psoriasis, and how many days will you continue this steroid, systemic steroid for pustular psoriasis?
Usually, I want to see some effect in the first in 4 or 5 days, and if that's the case, I tend to switch to taper quite rather rapidly towards another agent. It can be methotrexate, cyclosporin, citadine, whatever. But I must confess, yes. But I must confess that nowadays my most common approach to pustular psoriasis, in the absence, since spesolimab is not available, I'm using infliximab in most cases. Or you can use perhaps brodalumab, which is also very fast acting and also blocks IL-17.
Okay, thank you, thank you. Next, our panel of expert is Professor M.A. Kashan Chaudhary, sir. Have you here? Professor M.A. Kashan Chaudhary?
Unmute.
Yes. Yes, I can hear.
Please. Okay. Have you? What is your experience in your hospital for managing this psoriasis patients in COVID situation in Chittagong Medical College? You just comment, please.
Honorable Chairperson of today's international webinar, Professor Muhammad Samiul Haq, President, Psoriasis Awareness Club, Bangladesh. Respected keynote speaker, Professor Luis from Spain. Respected panel of experts, Professor Kamrul Hassan Jagidar, Chairman, Department of Dermatology and Venereology, BSMMU, Dhaka, and Dr. Rebecca Sultana, Head, Department of Dermatology and Venereology, Kurmitola General Hospital, Dhaka, learned participants. Today's speaker, Professor Luis, very nicely discussed the management of psoriasis in COVID-19 pandemic. His presentation was excellent and time demanding. Definitely, this lecture updated our knowledge in this regard. Psoriasis, we know psoriasis is a chronic immunological disorder. Here, what happens? There is overexpression of type 1 cytokines. And COVID also highly infectious viral disease caused by novel coronavirus, we contract through usually through inhalation. The virus infects the pulmonary epithelium, undergoes multiplication, and that virus is being presented by macrophage to B lymphocytes and T lymphocytes, which has been discussed very nicely by Professor Luis. And that activated B lymphocytes become plasma cell, which secretes antibodies, and that antibodies try to neutralize the virus. On the other hand, activated T lymphocytes secrete cytokines, these cytokines are responsible for cytokine storm in severe COVID. Now, our question, management of psoriasis in COVID in our Chittagong experience. Here, usually simple psoriasis patients, those patients who are not severe enough, we follow topical medication as the Dr. Rebecca Sultana mentioned earlier. We try to confine our patients, important topical steroids, and most patients improve. When patients with severe psoriasis comes to us, we are in trouble. And if these patients are getting systemic immunosuppressives and they are not COVID positive or they don't show any sign symptom of COVID, then we try to continue immunosuppressives. But we take in consideration regarding the age of the patient and comorbidities, regarding comorbidities that they have, like diabetes mellitus, heart diseases, or chronic kidney disease, or some patients suffering from internal malignancy, etc. In this situation, we avoid systemic immunosuppressive drugs. In some patients we get, they are taking systemic immunosuppressives and they recently become COVID positive. Straightforward, we stop that systemic immunosuppressive drugs. And when they become COVID negative, and by absolute proper documentation, and when we find that these patients are COVID negative, then we consider to start systemic immunosuppressive drug. Actually, we have a systemic non-biologic drug which has not considerable immunosuppressive effect. That is acetylene. We do prefer to prescribe acetylene when required in these high-risk patients. Now, we in this COVID era usually discourage patients routine office phototherapy. We ask our patients to stay at home and to expose themselves sufficiently in natural sunlight. Again, COVID is a very stressful situation. We are always in stress by hearing the number of deaths, by hearing the number of persons affected by COVID. This stress precipitate exacerbation of psoriasis. So we ask our patients to avoid seeing the televisions, to avoid hearing radios, to avoid reading even newspapers, so that they do not become panic by getting information regarding the death of the patient, by hearing the number of infected persons. So to relieve their stress, we ask them to talk with their friends, to talk with their relatives, and even to see movies and to read novels, etc., etc. In this way, we are managing our patients here in Chittagong, and actually most of the patients getting well. And thank you very much. And I like to pay my thanks and gratitude to Professor Lewis for his nice presentation. Thank you very much.
Okay, thank you, Professor M.A. Kashim sir, for your excellent comments. Now, I'd like to invite Professor Kamrul Hassan Jagiddas sir. Kamrul Hassan Jagiddas sir, can you hear me? Please unmute, please. Professor Kamrul Hassan Jagiddas. He is the chairman of department.
Can you hear me?
Yes,
Yeah. Thank you, sir.
Please
Hey,
unmute.
Professor Kamrul Hassan Jagiddas sir is the chairman of Department of Dermatology and Venereology, Bangabandhu Sheikh Mujib Medical University. Sir, please make a comment. Kamrul Hassan Jagiddas sir, unmute.
Can you hear me? Can you hear me?
Yes, sir.
Thank you very much.
You just comment about the today's lecture on Professor Lewis and all of everything.
Well. Thank you very much. First of all, I like to thank the organizers, the Psoriasis Awareness Club, who came up with this venture at this very COVID era, the association of COVID with psoriasis. And this was so time demanding, and it goes without saying. I was so pleased to listen to Professor Luis, who eventually hails from Spain, and I was astonished to hear the linkage with Neanderthal apes, the connection of COVID with Neanderthal origin. It was really a new information to me, and he belongs to Spain, which is near to Germany, where Neanderthal apes predominated many years back. And also he elaborated about the Wuhan variety and other dimension. of the origin of coronavirus. And he dealt with pathophysiology and other all the aspects of corona COVID infection in depth. And that was really a nice and elaborate, presentation of this very deadly disease. Regarding treatment, he cited so many examples of different countries, of different literature, different presentation, and that was newer in the sense in this part of the world. As you know, you are confronting the fifth wave, and we just embarked to so-called second wave. And in this part of the world, it was not necessarily that much devastating as we confronted in Spain. We know what happened in Spain, and we observed it from many, many miles away from in Bangladesh. What happens here, you see, unfortunately, the vaccination program here is only in up to date, till to date, it is about 3-4%. What fortunately enough that you have been vaccinated about 50% of your population. So your experience is vast. In our part of the world, though I belong to the university, the only university in Bangladesh, the COVID hospital, the COVID patients are being treated over there. As I am an elderly people, above 60, incidentally, I am not supposed to see the patients. My junior colleagues like Dr. Abu Hanna Choudhury and others, they usually visit the COVID patients in the wards. And what information I received from them, the the variety of patients they face with COVID infection, the presentation, the maculopapular rash and other things you mentioned, more or less similar presentations are found in COVID patients. The dermatologic manifestations are more or less similar in our population, as you have mentioned in your findings. And regarding the treatment, you see treatment already my colleagues from the two different hospitals, from Chittagong Medical College and Kurmitula General Hospital, they are more or less nearer to our population, and the presentation and treatment category is more or less same in on all over Bangladesh, including my institute, Bangabandhu Sheikh Mujib Medical University. Usually we stop treating those patients, only the mild COVID patients with mild symptom, we treat with, natural treatment like you see topical and other things. And those who are a bit severe, you see, who are on biologics or systemic drugs, we weigh the risk and benefit. We weigh the risk and benefit, and if there is no hematologic or biochemical or other findings like liver function, kidney function, other things, is everything okay? Sometimes we do continue, and we discourage to approach us. Most of the time, we want to cover with telemedicine or other things. And, in some cases, there are some emergencies. In that case, we have to take some different decisions, weighing the risk and benefit. And sometimes you confront, but necessarily what I like to inform that in the meantime, it's our, 1.5 year elapsed. In this period, most of the psoriatic patients might be, it's due to the, contracting COVID, they are not approaching us. And those who are approaching, mostly they are with mild symptoms and mild infection. So we are not necessarily in a dilemma to think over the treatment, and we can manage the cases easily. So far, we have managed the cases easily, but we are expecting a rush, heavy onrush after this COVID era over. Then we have to deal with different medications, different approaches. As regard your elaboration with vaccination, that was enlightening in the sense that you dealt with different viruses from like alpha, beta, gamma, and etc. Nowadays, we are confronting Delta variant, which is so deadly, as we have seen what happened in our neighboring country. We are we are neighbor of a big populated country like India, and we are at the utmost highest risk of contracting Delta variant, and which have been in now in pandemic here, and the wave has been shifted to our part of the world. And previously only the big cities were infected, but now it is spread all over the country, in the countryside, in the small towns, and everywhere there is a heavy unrest there of infection, onslaught, I should call it onslaught of COVID-19 infection all over the country. So today, unfortunately, 248 people died of COVID, and it is increasing day by day. I don't know where it will be stopped. And we are expecting and praying to Almighty about this population so that we get rid of this deadly, invasion of COVID-19. Anyway, the vaccine experience, regarding vaccine experience, we are having AstraZeneca. I myself have been vaccinated with AstraZeneca. Meantime, that is other vaccines are in progress. You see, they are most of the countries, they are sending us the gift from, we are getting gift from China, from America, from not necessarily from Russia, from India and other countries. The vaccines are, being sent to our people. So the experience with other vaccines, we are yet to see the consequence of vaccination, but the antibody studies, which was done in many cases, it's a different experience. Those who are COVID infected previously, they had got good antibody titer, and surprisingly enough, those who are even vaccinated with 2 doses of AstraZeneca, they are showing low titer. That's why that is why some people are depressed here, that so as to go for another vaccination or booster dosing. This talk is in progress or in offing. So these are the situation we are confronting here in Bangladesh. So at the end, I like to congratulate and express my deep sense of regard, rather, to a personality like Professor Luis, who from far away in Spain was kind enough to participate in this webinar to enrich us with the vast magnitude of his armamentarium of knowledge, or armory of knowledge and treatment and everything, all about COVID-19 association with prototypic disease of dermatology, psoriasis, which has got so many comorbidities and so many associations, so many complications, etc. And I thank you very much and the organizers to allow me to be a panelist in this August webinar. Thank you very much.
Okay.
Thanks the organizer.
Thank you, Professor
Thanks
Kamula
a lot.
Sanjay sir. Professor Luis,
you.
I think you are hurry enough. Will you wants to add any comments about Professor Kamula Sanjay comment and Professor Kashim sir? Professor Luis,
I
are you
think
here?
Professor Luis
Yeah,
has
okay.
left.
Okay, okay.
He left already.
Okay. Now he's ready. Okay, fine. Thanks everyone. Now, vote of thanks is given by. I would like to invite Mr. Anisur Rahman, Marketing Manager, Unimed in Health, to give his vote of thanks, because he's Unimed in Health is always support us. So I like to invite Mr. Anisur Rahman for giving his vote of thanks. Mr. Anisur Rahman.
Thank you, sir. Honorable Chairperson, respected doctors, and present my dear colleagues, very good evening. Assalamu alaikum. I'm Muhammad Anisur Rahman, working as a marketing manager, as Abu Hana sir said, in Uniderma. And Uniderma is a very diversified company who is truly focused on dermatology, all you know. I'd like to thank Professor Muhammad Samilok sir who is the president of Psoriasis Awareness Club, and Dr. M. Abuhena Chaudhuri sir, who is the Secretary General of Psoriasis Awareness Club, for organizing this webinar. And special thanks to Professor Luis for his excellent presentation. And I would like to especially thank our panel of experts, Professor Dr. Kamrul Hassan Jaigidda sir, who is the chairman of Skin VT Department, Bangabandhu Sheikh Mujib Medical University, Professor Dr. Muhammad Abul Qasim Chaudhuri, who is the head of Skin VT Department of Chittagong Medical College, and Dr. Rebecca Sultana Madam, who is she is also head of Kurmitola General Hospital. And I'd like to especially thank to the participating doctor for their nice participation. Without you doctors, this webinar cannot be successful. And I'd like to again thank to Psoriasis Awareness Club for arranging such type of program. And I would like to see you in another program in near future. Wish you very sound health and a good night. Thank you very much, sir.
Thank you, Mr. Anisur Rahman. Lastly, Professor Luis চলে গেছে, সেজন্য আমি বাংলায় চলে আসলাম। আজকের এই সুন্দর সন্ধ্যা না তো রাত হয়ে গেছে। আনিস সাহেবকে এবং ইউনিভার্সিটি নিউ হেলথকে আমরা অসংখ্য ধন্যবাদ আমাদেরকে হেল্প করার জন্য, এবং পাশাপাশি সবচেয়ে বেশি ধন্যবাদ যারা পার্টিসিপেশন আমরা জয়েন করছে সেটা। আমি লাস্টলি আমার প্রেসিডেন্ট এবং আজকের চেয়ারপারসন প্রফেসর সামিউল হক স্যারকে তার কনক্লুশন বক্তব্য দেওয়ার জন্য অনুরোধ জানাচ্ছি। প্রফেসর সামিউল হক স্যার।
Thank you all for attending this webinar. Dr. Lewis, he wrote in the chat box that he's leaving. Actually, they are very constrained in time. So maybe the time I asked him that in 1 hour it will finish. So anyway, he took another 20 minutes, he stayed with us, and he's a busy person, so he left it. Thank you all for attending. And I think this webinar will help us a lot, because this is a burning issue now about the COVID-19, and we are facing a lot of problems. Before, everybody is telling that the COVID has no relation with psoriasis, this and that. But now the evidence base is coming up, and this is a Symphony Health database shows that it has a great impact on psoriasis, those who have comorbidities as well as those who have psoriasis. So we have to think it twice before prescribing any drugs. We have to keep the patient in follow-up. Nevertheless, we have to think to treat them, to give them good advice. And about the vaccination, we have to think when we are, because mostly we are using the conventional treatment, that is methotrexate, cyclosporins and other drugs. So when we are giving these drugs, we have to be a bit cautious. We have to ask the patient after vaccination, they can take a rest for 2 weeks to reinstitute the drugs, or 1 month to reinstitute the drug. But the drug must be, this vaccine should be given to each and every patient of psoriasis unless there is any contraindication. At last, I should say that no matter where we live, people with psoriasis disease must have access to comprehensive and quality of care. And this includes access to COVID-19 vaccine to all our psoriasis patients. And I think this message should give to all the patients that they should get the vaccine, and the vaccine is the answer for this pandemic. Thank you very much for attending this webinar. Next time, we will try to give you another more burning problem. Thank you very much to all.
থ্যাংক ইউ আমার চেয়ারপারসনকে কথার ফুল জুড়ি না বাড়িয়ে আমি শুভরাত্রি বলে আজকে বিদায় জানাচ্ছি। সবাইকে শুভরাত্রি।
থ্যাংক ইউ, থ্যাংক ইউ।
Thank you, sir. Allah Hafiz, sir.
হ্যাঁ, ঠিক আছে আনিস, থ্যাংক ইউ ভেরি মাচ। তোমরা অনেক কষ্ট করছো কোভিড লকডাউনের ভিতরে, ঘরে বসে বসে সব জিনিসগুলো করেছো। দিস ভেরি গুড। জাকিরদার ভাই, থ্যাংক ইউ। আসসালামু আলাইকুম।
হ্যাঁ, ওয়ালাইকুম সালাম।
হ্যাঁ, আমি খুব খুশি হয়েছি জাকিরদার ভাই।
না না,
ভেরি নাইস।
আপনি খুব ভালো মানুষ, আমাদের খুব কাছের মানুষ আপনি। আপনার
Thank
ব্যাপারটা
you.
আলাদা, বুঝছেন, স্বাভাবিকভাবে আপনি আমার
হ্যাঁ।
শ্রদ্ধেয় বড় ভাই, বুঝছেন।
না না না, এখন হচ্ছে কি
জি।
এত সব ঘরে বসে বসে কাজ হচ্ছে তো
জি, হ্যাঁ,
এখন আর ওনার সাথে আমি কমিউনিকেশনটা থার্সডে রাত্রে করছি যে সে
আচ্ছা,
কনফার্ম
আচ্ছা,
করছে,
জি,
আর তারপরেই থার্সডে
জি।
না আমাদের এখানে বন্ধ,
জি।
তাদের ওখানে স্যাটারডে সানডে কোনো যোগাযোগ নাই,
হ্যাঁ, বুঝছি,
বুঝছেন।
সেই।
আমিও একটু কনফিউশনে ছিলাম যে
আচ্ছা, আচ্ছা,
রিপ্লাই
আচ্ছা, সেই।
পাচ্ছি কিনা।
আচ্ছা,
এখন
আচ্ছা।
আনিসকে বলছে ওই ঘরে বসে উঠে, এখানে
হ্যাঁ, হ্যাঁ।
লকডাউন, অফিসেও বন্ধ। এখন আমি কিন্তু খেয়াল করি নাই যে আপনাকে
জি।
তারা ওইভাবে আসলে এটা একটু প্লিজ ডোন্ট মাইন্ড,
না না, ওটা
মাইন্ড
কোনো
করেন
ব্যাপার
না,
না, ওটা
ওটা
না।
মাইন্ড করেন না
আচ্ছা,
অ্যাকচুয়ালি।
কিন্তু না সামিল ভাই, আমি ঠিক বুঝে ইয়ে আর কি, ডক্টর লুইস আর কি, উনি যে ভ্যাকসিনেশনে যাবেন, এটা আমি আমরা ভাবছিলাম যে এতে সীমাবদ্ধ থাকবেন হয়তো, মানে এটা টপিকটা ছিল তো যে ওরা কিন্তু,
ম্যানেজমেন্ট
হ্যাঁ, ভ্যাকসিনেশন উপর খুব গুরুত্ব দিচ্ছেন, তাই না?
ভ্যাকসিনের এখন সব জায়গায় ভ্যাকসিনটাই বেশি গুরুত্ব দিচ্ছে,
গুরুত্ব দিচ্ছে আর কি, সেটা দেখলাম।
কারণ
এটা
ভ্যাকসিনের উপর অনেক কিছু ডিপেন্ড করছে
না,
তো এখন।
আসলে এটা তো অবশ্যই আমাদের দেশেও
কারণ
চিন্তা করেন।
এখন প্যাথোজেনেসিসে দেখলেন তো যে
হ্যাঁ,
কোভিড
সেটাই।
এর প্যাথোজেনেসিস আর সোরিয়াসিস প্রায় একই রাস্তায় চলছে,
জি, জি, হ্যাঁ, সেই তো আমি
একই রাস্তায়
জি,
চলছে।
একই রাস্তায়
অতএব
চলছে।
হ্যাঁ, ভ্যাকসিন ছাড়া কিন্তু আর উপায় নাই,
না, সেটাই।
ভ্যাকসিন দিতেই হবে।
আমাদের দেশে তো, আমাদের তো ওই মানে ওই নতুন এক্সপিরিয়েন্সটা পাবো মাত্র, নতুন যেগুলো আসছে,
হ্যাঁ
মডার্না, তারপর
হ্যাঁ
যেগুলো
হ্যাঁ
আসতেছে,
ও তো
আমাদের
প্রথমেই
দেশে তো
বললো না
সেই
চাইনিজ ভ্যাকসিন খুব একটা
জানি বলেছিলাম, দেখলাম তো, শুনলাম, বুঝছেন, সেটাই। কাজে আমাদের ইয়েটাও ধরেন, আমরা খুব একটা ওই যে বর্তমান যেগুলো আসছে, এদের কম বেশি আমরা পরবর্তীতে জানতে পারবো আর কি, বুঝছেন।
হ্যাঁ
এটা তো প্রিলিমিনারি
ঠিক আছে।
ইয়েতে আছে আর কি, সেই।
আচ্ছা,
আচ্ছা।
একটা একটা ছোট